You know, I think what we're finding is, I mean, you know, obviously a urologist won the Nobel Prize in figuring out that castrating a rat in patients, resulted in a reduction of prostate cancer growth, and it sort of has been the foundation for many, many years, obviously. But I think we're coming to the realization that it has some bad side effects, and so. Oliver, I know the Europeans have tried monotherapy using using anti-androgens. Kind of, from the medical oncology side, very respected guy. I mean, kind of what are your thoughts? Is this going to continue to be the norm forever and ever? Because patients don't really like being on long-term LHRH therapy.
First of all, it's pretty remarkable that a seminal paper in 1941 still influences our practice today. I mean, can you imagine in oncology how much has changed? But we still have androgen deprivation at the heart of our prostate cancer therapies, and that's Dr. Huggins and his Nobel Prize from 1941. So, one day you're going to think we're going to make another large advance. I think Dr. Shalley and his isolation of the LHRH and the hypothalamic control of pituitary function leading to the whole LHRH analog, GnRH analog, that was a wonderful advance because then men could be able to keep their testicles with them while still having androgen deprivation. But, it's interesting, the anti-androgens we have today are really superior to the ones that we had yesterday. And these trials are now evolving. We do know from the older anti-androgen literature, the bicalutamide, flutamides, that you really could not get the degree of androgen deprivation that was necessary to optimally control metastatic disease. So you might be able to do fairly well for those with non-metastatic disease, but when it became metastatic, it really turned into a bit of a different beast. And now there are people looking at whether or not anti-androgen monotherapy with some of the new agents might suffice in this situation. And you would have several potential advantages and some disadvantages. Number one is you actually have a libido-sparing effect. So men can be on the anti-androgens, have a little better libido. You actually end up with some bone-sparing effects. It turns out that you end up with a higher estrogen. As T goes up in a compensatory manner, you shunt some over to estrogens, keep your bone health a little bit better. Problem is that you do have some gynecomastia, and that can be a very problematic issue, and in fact is at times even extreme. So if you're going to be using that approach, which as of yet is not really proven, you do need to think about gynecomastia as being a rate-limiting step.
For those of us that have been around a long time, what was a pretty good drug was DES.
Absolutely.
Had it not been for the thromboembolic events that was associated with the drug, it was actually a pretty good drug. Ken, does anybody in your office, because I know you can get DES compounded, is anybody still using it?
I was using it for a while when we didn't have all these new agents, but as these new agents have evolved, just because of that thrombolytic risk, we've kind of stepped away from it.
Because again, it did avert.
It did work very well, right?
A lot of these issues. So
interestingly, there's a UK trial that's going on with transdermal estrogen, which theoretically might mitigate some of those risk factors. And I think you're absolutely right, because it's a generic DES, and you have to get it through a compounding agency. It's not well marketed. We go back to all that VA buyers data, which is on 1 and 3 milligrams. It's all rather old, trials and with a lot of various heterogeneous populations. Paul Schellhammer, is a huge proponent of getting back and thinking into looking at the estrogen for ADT because of the beneficial effects of keeping your estradiol up. So it's an area that is ripe, and so there is this cool trial that's going on in the UK on transdermal. So we should all keep an eye on that.
That's great.
And you see patients internationally from all over the world who often come in on Still Be Strong. It's very easy to forget that if it's not part of your own armamentarium, right, it doesn't mean that you're not seeing patients as a second opinion who are on these estrogen medications.